Hello, I'm Cornell Clayton. I'm the director of the Thomas S. Foley Institute at Washington State University. And on behalf of the Institute and on behalf of the College of Liberal Arts at Washington State, I'd like to welcome you to our event today. I also want to begin by thanking Brian Pitcher, who's not here right now but will come along a little bit later, who's the chancellor of the River Point campus here, for letting us use these wonderful facilities for our symposium. It's actually very appropriate that we are holding this symposium on the River Point campus, both because of this campus's concentration of academic and scholarly resources in the areas of health sciences and healthcare policy, but also because of the role that Tom Foley played working together closely with other city leaders in making this campus a reality during his 30-year career in the U.S. Congress. In fact, as in partial recognition of that unique commitment to Spokane as a city and to this campus in particular, the Foley Institute has just recently opened a permanent display that features Tom Foley's Congressional Speaker's Office. It's over here in the main administration building in the library on the second floor. And it features the Speaker's desk and his office furniture. And at least temporarily, it also features a sculpture that was recently donated by a well-known local artist, Sharon Taylor Hall. And it's really a very handsome sculpture of Tom Foley. And so I want to encourage all of you to take a few minutes before you leave campus today to walk across the way to the main administration building and take a look at that exhibit. The institute that honors Tom Foley does so by providing resources for public policy research and by providing opportunities for students to become involved in public service. We also have a primary mission on campus to provide programming such as today's event that educates both students and the broader public in the state of Washington about matters of public policy concern and public affairs. Yesterday when I was driving home from work and I was thinking about today's event, I actually heard one of the stories about the Supreme Court's pending case involving the Affordable Health Care Act. And as you can imagine, it involved the usual breathless hyperbole that has come to be associated with healthcare reform in discussions recently in the United States. Depending upon which side you listen to, the Affordable Care Act either represented the end of American freedom and liberty as we know it, or it represented the only solution to the ills that confront our healthcare system. And those who oppose it are either ignorant bumpkins or partisan opportunists. Today's symposium eschews both of those mischaracterizations, both of the Affordable Care Act and of the discussions surrounding healthcare reform more generally in the United States. As the title of the symposium reflects, we want to engage in a rational discussion about healthcare reform. We believe it's high time that conversations about healthcare reform in the United States become more mature, more informed, more educated, and more reflective. And we hope that today's symposium is the start of beginning that kind of more mature discussion about healthcare reform. We will begin today with a panel that will discuss the challenges surrounding the implementation of the Affordable Care Act and other recent reform measures. This panel has 4 speakers, and I will introduce those 4 speakers in just 1 minute. And it should last for approximately an hour and a half until about 2:30. We will then have a short break, during which time I encourage you to come outside here and we'll have some refreshments and some coffee. And it might be a good time to take 5 minutes to walk across the way and see the Foley exhibit as well. At 3 o'clock, we will then reconvene in this room for our second panel. That panel will focus on the political challenges facing healthcare reform as we move forward. And that discussion should last until about 4:30. And following that, I invite all of you to join us for a wine and cheese reception that will take place in the atrium just around the corner in this building. So now let me introduce our first panel. We are honored today to have with us, first of all, Mary Selecky, who is the Secretary of the Washington State Department of Health, and she has served in that position since 1999. Mary is one of the original creators of the Washington State Department of Health and has been an active participant in developing state, local, national, and public health policies. She is the former administrator of the Northeast Tri-County Health District and is a clinical professor of health services at the University of Washington School of Public Health. She will be followed by Professor Tom Schaaf, Tom Schaaf, who is the Assistant Medical Director for Group Health Cooperatives, Eastern Washington and Northern Idaho District. He is a board certified in family medicine and has practiced at Group Health in Spokane since 1992. He will be followed by John Pierce, who is the Senior Vice President and the General Counsel for Premera Blue Cross. In that capacity, John is responsible for the legal and regulatory affairs of the Premera family of corporations. He received his law degree from Stanford University Law School and his Bachelor's of Science degree from WSU, and we are proud to have him as one of our alum. Our final panelist and moderator for the panel is Patricia Butterfield. Patricia is the Dean and a Professor of Nursing at Washington State University. Professor Butterfield earned her MA in Public Nursing from the University of Colorado and her doctorate degree from the Oregon Health and Science University. Over her long career, she has taught at multiple universities, including Boise State and the University of Washington. Her areas of scholarly interest include environmental health, nursing, and occupational and environmental health in rural settings. So without any further ado, I'll turn the time over to Patricia Butterfield.
Thank you, Cornell. It's my pleasure to have each one of the panelists speak for 5 to 10 minutes about how they'd like to see our topic informed this afternoon. Following that, beginning with Dr. Selecky, then we'll begin with the discussion. For the discussion, we'd like each one of you that have a question to come forward to the microphone so that you can be heard and recorded. And with that, I'll turn it over to Mary Selecky. Thank you, Mary.
Thank you. Well, good afternoon, everyone. I'm Mary Selecky, Secretary of Health, and first I have to tell you, my home is in Colville. So I'm close to home here, and it's very nice to be in Eastern Washington. And last week I was with Mary Ann Keogh at an event where we had a couple hundred people. Maybe that was this week, Mary Ann, on Monday it was. It was a very good symposium talking about much the same topic today, because I think we're all very curious about that. But I do want to first acknowledge my fellow panelists. Between Premera and the Group Health and some other insurance companies in Washington State, we as a state, even in these tough economic times, are able to buy childhood vaccines for every child born in this state. Some of that is supported by the federal government, but also by our providers in the community and our insurance companies. So I thank you for that, because it makes a difference in that, and I'll come back to that at the end. And certainly, we appreciate every nurse you graduate, Pat. Thank you. We'll put them to use very well. So I want to bring greetings from the governor. We have a very active health cabinet that all of us in health agencies, the Health Care Authority, which is our Medicaid agency, the Department of Social and Health Services, and my department sit on. And just recently had a couple-hour session with the governor about the Affordable Care Act, but also the work that has been going on in Washington State. But I want to really focus on our topic today. And really, when you think of health reform, you might think of buzzwords you hear in the media: Obamacare, the debate over providing health insurance for everyone, Medicaid, Medicare, the Supreme Court. But something tells me you don't think about insurance coverage for your college-age kids to age 26, and so perhaps some of you under age 26 are still being covered through your parents' insurance. First dollar coverage for preventive clinical services. Money and coverage should not be a barrier to getting your colonoscopy, your breast and cervical cancer screening, and all the other preventive services we should. No pre-existing condition exclusion, or the value of prevention and wellness, which is the business that I am in. A big part of the change that's come as a part of the Affordable Care Act is a renewed focus on the value of prevention and wellness policies. So let's look at what's been happening in our state in terms of health reform in Washington State. Now, I'll give you a few statistics. More than 2.4 million Washingtonians no longer have a lifetime limit on their health insurance plan, thanks to health reform. More than 1.2 million Washingtonians have either received or added coverage for important preventive services. More than 62,000 seniors received a significant rebate to help cover prescription drug costs that hit them because of the donut hole in 2010. 52,000 young adults under age 26 have gained health insurance coverage through their parents' plan. Those things are already in place. About 2 weeks ago, the governor signed the law that creates the Washington State Health Benefit Exchange. It creates an online marketplace to allow people, small businesses like my friends who run the Hallmark shop up in Colville, to have a one-stop shop for comparing and buying competitive health insurance. This is especially important to small businesses who often pay more than large businesses to cover their employees. So let's make a little shift here. This isn't about illness care now. I really want to talk about the prevention pieces. I have had the fortune of working in local and state government for 37 years, 25 of those in Ferry, Pend Oreille, and Stevens counties, most recently certainly at the state. I've been in public health. I'm in my 34th year in that. And indeed, I've not ever seen a federal piece of legislation, let alone a state piece of legislation, that embraces prevention and wellness in the way that this does. It's grounded in a national prevention strategy that for the first time ever pulled together 17 federal agencies, offices across the federal government to look at what is it that their department does to influence health. Whether it's the Department of Transportation, whether it's the Department of Agriculture, and you think about departments that don't have health in their name and what they have to do with it. And I'll give you a few examples with transportation. For example, we are helping communities create safe walking routes to school. You know, a lot of parents are concerned about the fact that the schools have gotten built a little farther away, put their kids on a bus, and they get on a bus at the end of the day. Working together with transportation to have sidewalks that are continuous up to a school, things that are safe, and you make sure the kids can cross the street well. When you look at this circle, which I recognize is not easily readable, and I'll just focus on really several pieces of it. At the center of the circle, the goal is to increase the number of Americans who are healthy at every stage in life. And in the middle, it's about the community and system level changes, like the smile I had on my face saying that you will be a smoke-free campus. That's a policy change, and I say thank you for that. And just one quick story. A number of years ago, I was at a class presenting at the University of Washington, and a hand went up, and I happened to know this individual, and she said, "Why don't you work with the university to make this a smoke-free campus?" And I looked at her and I said, "You have more power than I do. I don't go to school here." And indeed, the class started talking about it, and within a year, the University of Washington was smoke-free. So it really is about what we do about this, not about what government does about it. And on the outside ring, to give you that example, the change starts with you because it takes all of us to be healthier. So we're focusing on chronic disease because it's chronic disease that's basically eating our healthcare cost lunch. And what you eat for lunch is also part of that. We really want to prevent chronic disease, and these diseases that impact you and your loved ones are heart disease, cancer, stroke, and diabetes. All of them have one thing in common, and that's the use of tobacco. So again, a smoke-free campus encourages someone not to smoke. But they also have to do with our lifestyles, how sedentary we've become, how used to being in front of a computer screen rather than doing some activity in the evening. So we've got to have some incentives and encourage people to get out, move about, eat a little better. As part of the Affordable Care Act, there is a program called the Community Transformation Grants. Washington State was highly competitive and one of 61 awardees across the nation. In fact, 4 of us in Washington State, 2 tribes, Tacoma Pierce County Health, and the Washington State Department of Health. We're working with 36 counties and with the other 3, and that would be Snohomish, King, and Pierce. to work on some issues like policies, smoke-free parks, smoke-free apartment buildings. We're working with our housing authorities because they want to turn over their properties into smoke-free. Corner stores having fresh fruits and vegetables. And there's an example right here in Spokane, where the owners of a corner store realized we haven't ever sold fresh fruits and vegetables, and they were paying attention to the fact that the residents in their community had to take 2 buses to get to a big box store. They've totally turned around what they're selling in their store. They personally decided they wouldn't sell cigarettes or alcohol. No one pushed them at that, but they want to have a healthy place that the community can feel like it's the center of their activity. So you've got policy examples. Environment, zoning ordinances that allow a farmer's market to locate in what otherwise might have been an area of the town where it wouldn't have been allowed. And then programs like us, Department of Health, buddying up with Moses Lake, where they focused on linking walking trails, promoting breastfeeding in public places, creating a community garden, improving school nutrition, and making changes in the city code to support people's health. So when we look at this, we really have to pay attention to what we're doing, but the spheres that we get to influence. Healthy eating. My guess is that you go to a meeting sometimes and a meal is served. We've got available choices that you can make as somebody who's planning a meal, whether it's a big banquet or a small, intimate breakfast meeting, in terms of making healthy choices. We have a brochure on our website called Energize Your Meetings. Make some simple changes in the worlds that you control, including your own. Active living. Wouldn't it be better if we were all more physically active? I just heard about running and being on corporate teams while we were waiting to get started here. Good for you guys, because that's not what I do. I walk, you can run. Preventive health services. I went to school at the University of Pennsylvania in Philadelphia. Benjamin Franklin was the founder of our university, and he was wise 200 years ago, saying, an ounce of prevention is worth a pound of cure. And indeed, that is the case in terms of us as individuals, but also our communities, and tobacco-free living. So how are we doing that in Washington State? And I already mentioned that we are working across our counties, across all the boundaries. No one really just stays in place. We're a very mobile society, and we want to have some similar things, particularly where you've got similar populations. What works in Spokane is going to be very different than what works in Federal Way. The populations are different, the customs are different, yet we're all in the same state. What you're seeing is kind of how we're doing this, and we have some areas in the state that are hubs for the counties around them. That's what the colors are about. And Spokane is one of those hubs. And in fact, yesterday, Torney Smith, and some of you may know him, was over in our office at the Department of Health working on some of the issues that he's going to be focusing on with all the counties right around us. And the idea is to strengthen our regional partnerships, because none of us can do it alone, leverage resources and funding, and share the technical expertise. So how can you help? You can get involved. You can get involved in your community. You can get involved from your professional end. You see it, one of the circles says, promote 1 million lives. That's a campaign going on by the Centers for Disease Control, and it focuses on the ABCs, just like you learned in kindergarten, with a twist. Take an 81 milligram aspirin every day. Do you know your blood pressure? Do you know your cholesterol? And if you smoke, quit. And if you know a smoker, help them quit, the ABCs. If we did that, we'd improve the lives of the people with those million hearts. So I'm going to wrap up with a commercial. Anybody see the Today Show today? Anybody see the Today Show? I was on it in a clip, 7:15 this morning. But it was a sad story. It was a sad story about a mom and her baby who had whooping cough or pertussis. There's also a radio clip that we've started to run, and I'm on that radio clip with a mom who's 19, whose baby died of whooping cough, all within this last year. Little did those moms know that their dry cough was whooping cough, because they weren't that sick. And they passed it on to their babies. One baby survived, one baby did not. Every one of you can help cocoon and surround our babies and each other by getting what is a Tdap booster. The vaccine wears off over time. Everyone over the age 7 needs a booster shot, Tdap. You can get it in the drugstore, you can get it from your provider. If you dream about a baby, you have a baby, you think about a baby, please help us do that. So I really ask you, because yesterday or Tuesday, I declared an epidemic in our state. We have 640 confirmed cases, and what we know is only about 10 to 12% are reported, because people don't get so sick, but little babies do. And we know we already this year have had babies hospitalized. So I leave you with that important prevention message. Cover your cough, wash your hands, stay home when you're sick, get a flu shot and a Tdap boost. Thank you.
Thank you, Mary. Our next presenter, that was great. Our next presenter is Tom Schaaf.
So I'm Tom Schaaf. I'm here actually with 2 hats. One is the medical director for the group health clinics in Spokane. I'm also associate medical director for care system redesign in the Spokane area, which is probably the more fun thing right now. Now that I have an honorary professorship, I appreciate that. I'll be talking to you about tenure after the presentation. The PowerPoint thing is too long. My talk's too long. I'm going to try to be as brief as possible. Glenn is nodding again. Okay.
Same thought.
Yeah. But what I'm going to try to do is draw connect the dots between healthcare reform, the need for it, what group health is doing right now around our delivery system to try to control costs and improve quality, and what our future vision is to meet the needs of the population here in the next few years. So just at a glance, we actually were formed about 60 years ago in the Puget Sound region as a new way of delivering health care that could be affordable for the people of Puget Sound area. We're still consumer governed. We've got about 600,000 members statewide in North Idaho. Group Health Physicians is who I work for. We're a separate organization that has about 1,000 docs and other providers statewide. As you may have heard, the language around healthcare reform has gotten a bit contentious. We're realizing that regardless of what happens to the ACA, that some kind of reform has to happen. We are doomed, is the polite way to put it, if we don't have some reasonable level of reform. Healthcare costs are rising. The percent of people's incomes going to health insurance is rising. And people are making unfortunate decisions because of the cost of health care. There's an economic law called Stein's Law. If something cannot go on forever, it will stop. And eventually what we're doing now has to stop. And our choice in the future is to either wait for price cuts and rationing or to have a well thought out and implemented healthcare system with aligned incentives amongst all parties. There's this concept of the triple aim that basically says to have a functioning healthcare system, we have to have lower costs, better quality, and better service. And my contention is that we can, in fact, do that if we do things the right way. So I have 2 things that I think need to be addressed. One is the current fee-for-service system, and it leads to higher cost and lower quality, and that just tweaking it is not going to be workable in the long run. It incentivizes doing more stuff without paying attention to what that stuff is. The other is the cost of not having everyone insured leads to cost shifting, population fragmentation, and frankly, it is part of the reason why healthcare is so complicated and so costly in the United States right now. So the ideal healthcare system has got to have these 5 qualities. Has to start by being patient-centered. It needs to meet the needs of patients at all levels. Reliability and safety has got to be baked into the system, both operational and cultural levels. There's got to be seamless coordination between care teams, both between physicians and all known sites of communication disconnect, such as when you go in and out of the hospital. And that affordability is a key feature to be sustainable. So what we did to start was build something called the Patient-Centered Medical Home. And this is based on the knowledge that primary care is the key to affordable health care. States, communities that have good primary care have better health care at a lower cost. I'm going to skip through some of this stuff. But we realized that we were suffering because our docs were being pushed to just do more stuff and not have the time and the resources to do it. And the primary care medical home, and I know, Glenn, you're going to talk about this more later, is a way of building a resource for patients and their families to have a system to navigate the complicated medical world and get the best care at the start. As we built it, we did a pilot in Factoria where we tried this out. Lo and behold, it worked great, but we had to spread it to 26 clinics across the state, and we spent a lot of time with frontline doctors and nurses and all building standard work for communication, for physicians and other staff around how we handled incoming calls and virtual medicine, your ability to do phone visits and email visits. We actually hired more docs, decreased panel sizes, increased our visit time, so there's no more than 2 visits an hour, and did some work around how to make sure that when you walked in for even a sprained ankle, you could get comprehensive care at that visit, and with the goal of getting decreased costs and better outcomes. And as all of these parts work together, as this circle moves on and on, we're getting better at it and getting better results. We move through some of this stuff. So anyway, our 2-year results into this program showed increased quality, better patient and staff satisfaction, decreased emergency room utilization, and decreased costs. So all good so far. For every dollar we invested, we got $1.50 back. So far, so good. However, this works well in a prepaid commercial environment, right? It's not affordable in a Medicaid environment. It's still very physician-centric and doesn't adequately address population and provider variation. And there's still a lot of waste in our system. We also realize that primary care is key, but without integrated specialty, we don't have the ability to control cost and improve quality that we have at places like Bellevue and Capitol Hill, where we have the full range of specialty services. So that has to be figured out, especially in communities like Spokane, where right now we're primarily family medicine. When 2014 rolls around, there are going to be a bunch of folks who have insurance who are going to need primary care docs. Where are they going to come from? We also know that there is not a big bucket of money that's going to come with this. There's, if we're lucky, a small bucket of money. Demographics as new population could be challenging. So we're working right now on what I term Medical Home 2.0, where we work on the challenge, how do we keep the key elements of the medical home while more effectively meeting the needs of these diverse populations? We really need to enhance how we do team care. And the makeup of the team is going to change. We know that the standard work that we have now is clunky. It needs to improve. We need to become more effective at working with community partners in meeting the behavioral elements, social behavioral determinants of healthcare outcomes. Clinical integration is a project I'm deeply involved in, where we're meeting the need for greater specialty integration, not by just hiring a boatload of specialists into Spokane, but by collaborating with folks like Columbia Medical Group, Providence Healthcare, a variety of specialty groups to create a new model of integrated care in Spokane, with the goal to use this new model statewide as we figure it out here and make it succeed here. Last but not least, we're working on payment reform, so as we build this integrated system, we're going to be paying physicians on a population basis more than a fee-for-service basis. We're going to build in incentives for quality access and service, and we're going to try to recognize the value of things like virtual care, of using electronics, communication tools to maximize care with the best service to the community. We need to recognize the value in our payment systems of things like coordination of care and the time and energy that goes into shared decision-making around the medical care that you guys receive. That's about a 2-hour lecture, crammed into, I think, about 10 minutes, and I look forward to your questions later.
Thank you, Tom. Our third panelist is John Pierce from Blue Cross Premera.
Great, thank you. Thanks for being here. Thanks for having me. As was mentioned, I did go to Washington State some years ago, and I grew up in Cheney, since we're talking about local towns. So it's great to be back. I consider this to be home, so it's a wonderful thing. I actually live sort of in this shadow of Husky Stadium, so it's nice to be closer to a little crimson and gray for a change. So thanks for having me here. And I know we're all well past show and tell, but I was cleaning out my basement about a month ago, and I came across something that my mother had saved for me. And this happens to be her original hospital bill from when she delivered me some many years ago. I won't actually share the number of years, and a signed receipt. And so this was back in Kansas where I was born. And for an 8-day uncomplicated stay in the hospital, it was $115. And her copay was $26 of that. So that will fold a little bit into the theme of my talk, which is a little bit about the cost of health care and how we need to make sure that we focus on that, because 8 days in a hospital, Tom, if I'm correct, is no longer at $115.
It's a little higher than that.
Yeah. And so whether you think I impart any wisdom today, at least I will go away believing that I'm a very good value. So my theme is really that whatever you think of the ACA and how successful it might be and whatever the Supreme Court might do with it come June, there's still a lot of work to be done. I'm going to talk about it both theoretically and then a little bit more practically from how Premera, an insurance company, views that. In particular, we're very focused on the issue of the cost of care. What we believe we can bring is help to create a sustainable healthcare system. That's our vision, and we want to make sure that we contribute to that along with the fellow panelists, you in the room, and the rest of the members of the community. So the cost issue is really not treated very carefully by the ACA, in our opinion. There's a lot of work that needs to be done to focus on the cost issues. Even the assumptions that are built into the ACA indicate that the costs are going to go from about $9,000 a year for each member of the population to about $14,000, or a 53% increase. So there are going to be continued upward pressures on the cost. It does a lot to address the issue of access, brings a lot more people into the system, but there will be a cost to that, and we as a society need to be careful to focus on that. So the costs are driven by the aging population, new technology, unhealthy lifestyles, just practices of medical practices. And those are really not the central focus of the ACA. It's really focused very much on expanding access, giving people additional ability to access the care. And just a small example of that is in February, the government announced the results of the high-risk pools that have been put in place by the federal government to span us to the 2014 period when there'll be the new exchanges in place that Mary referenced. And the cost of those pools are twice what people expected they would be. So 100% higher cost for those pools. Again, these are people that have been outside the system, people with high cost medical conditions, so it's understandable that they would be high cost. But the original projections were that it would be about $13,000 per enrollee per year, and it's actually costing around $29,000 per enrollee per year. And that's compared to the average for state high-risk pools of about $12,000 per year. So the point of that is there are huge costs that will be coming into the system from people that have been uncovered, and the potential adverse consequences of that need to be taken into account. We had our own example in this state back about 10 years ago when we had our own version of state healthcare reform, and it greatly expanded access, but it didn't do things to really require people to be part of the system. And actually, as a result of that, eventually, because of the amount of money that health plans, including the company I work for, lost, all the plans stopped selling individual insurance. And just a little example we have of that is that we had one of our members who wrote us a very nice letter. She had become pregnant, so signed up for coverage, delivered her baby, wrote us a very nice letter saying, really enjoyed your coverage, great service, and I'm going to drop my coverage now because I've had my baby, but if I ever get pregnant again, I'll be sure and sign up for insurance coverage. And so, you know, obviously that's not a concept of insurance, and it needs to be everybody into the system, everybody paying their fair share of the system. So we think that's one of the things that needs to be looked at closely as we move into the brave new world, again, notwithstanding what the Supreme Court might do. Another example that I look at is the example of the basic health plan in this state, which is a very laudable program. People favor it, insurance companies support it, everybody really is behind it. But because of state budget constraints, over the years, that has either been on the chopping block or cut back year after year after year. And I think this year it's going to get through the budget crisis. So there's that limitation on services for people that are indigent. At the same time, we're creating a federal program that provides coverage for indigent and gives them subsidies. And I think at some point we as a society need to reconcile the fact that there shouldn't be a difference just because the state has to balance a budget and therefore is throwing people off the rolls, and the federal government, because they get to mint money or because they're putting new programs into place, can expand those roles. And I think that's a real consideration that we as a society need to take into account. So a little bit more of the practical focus of Premera. So we are very focused on what Mary already talked about, the exchanges. So as of 2014, there will be new programs for people, particularly in the individual and small group market, to more easily access health care, to get better information, more comparable information with a defined set of benefits, all of which we think are laudable goals. And those come along with significant subsidies. It could be up to 100% subsidy for people that need coverage. And what we're focused on right now is the work toward that end. And while 2014, particularly when the law was passed, seemed like a long way off, it's really not very far away at all in terms of things like designing products, and we actually don't have all the details of what we need to have to design a product, to start to price those products, file them with the state to get them approved, put the systems in place to administer them, to deal with this world where we have about 100,000 members on our individual program. All those people will have different options, different choices, and so just the administration of dealing with those is going to be a significant challenge for us. And our experts evaluate the additional cost of just going into the exchange environment because of the defined benefits to be about a 25% increase just right out of the blocks. So while a lot of people are going to get subsidized, other people who aren't subsidized will all of a sudden, because of the exchange, will be paying 25% more than they were the day before. And just a little complexity, oh, by the way, those people that are grandfathered, let me explain that term a little bit. You may recall from the public policy debate, people said, if you like your health plan, you get to keep it. And that's the case. So if people want to stay on their very same plan, they can do that. And some have chosen to do so. And those are what we call grandfathered plans in our business. So those people can keep those plans, and they don't have to go into the exchange, and they don't have the same cost increase. So we've now got this populace of people with sort of a frozen benefit, a frozen in time benefit. They don't get the advantages of improvement in products and things like that in order to get the lower price. And it just creates an additional administrative complexity that I'm not sure people took into account when the law was passed. So we think the exchanges are a great idea. The notion of a marketplace, more of something where somebody can compare products and companies side by side. I think the jury is still out in terms of the level of subsidies, how much money will be available to bring new people into these products. And there's still a lot of questions in terms of what the benefits will be. HHS is helping decide and has given it to the states the authority of deciding ultimately what the essential benefits will be that go into those products. And then it's already been alluded to a little bit, the Supreme Court and what decision they might make. It's been kind of exciting for me as an attorney at a health plan for the first time in my life to have just about everybody in my company, I think, knows the name of all 9 justices for the first time. And have been involved in some pretty interesting conversations about what might or might not happen. People from time to time ask me to sort of handicap that horse race, and I'm not in a position to do that. I will say that after the arguments, there's a much greater sense that they may do something to overturn some or all of the law than there was before people went into those arguments, and just creates a little bit more uncertainty for us. And for the most part of my job, people don't come into my office asking for uncertainty. They would rather come in and get a little certainty from me, and it's harder these days to be able to give them that certainty. Whatever the Supreme Court decides, then even if they strike down the entire law, I think aspects of the law that have been put in place will continue. Things like the exchanges, without the subsidies, may continue in some capacity. And so we will deal with and work through those uncertainties. And our focus, again, is going to be on addressing the costs of the administration that we perform. And we're also working with providers, hospitals, doctors to make sure that we focus more on paying for value as opposed to just paying for number of services. Tom talked about that a little bit. We're also looking very closely at improving the wellness of our members. We've started that with Premera. We sort of treat ourselves within our own little test tube, and we work on ourselves in terms of plans that we can put in place to increase wellness. And it's been very exciting. For example, a couple of years ago, we put in place a program where, to make it simple, for people that volunteered to participate in the program, we weighed all of us, and at the end of the year, we weighed all of us again. And if we achieved certain thresholds of weight loss, then we would get a Starbucks card. And so we were successful in that. We, as a company, lost 5,000 pounds. So it's just a step on that journey toward wellness that we all talk about. So 2 solutions that we talk about at Premera. One is to reform the payment system to focus more on paying for outcomes, paying for value, and we're engaged in projects with about 1,500 physicians across the state at this point to do that, where as they improve quality but also improve the efficiency of the work that they do, eliminate the variation in the cost of care, that they can benefit from that financially. And then secondly is to give consumers both a greater voice and a greater financial responsibility in terms of how we can be successful, so they think more about how the healthcare dollar is spent. So the person that's making the healthcare consumption decision is also responsible for the payment decision. And to some extent today in the society, those 2 things are separated. And we're trying to give everybody a greater incentive to focus on their own health and wellness and well-being. And those are my comments. Thank you.
Thank you. Thank you, John. Good afternoon. I'm going to speak with you about the connections between reform and workforce. No matter how we translate this, healthcare is about people caring for people, so I'm going to address it from that lens. Today's healthcare providers were educated in a different world with different values and parameters, and now are being a part, oftentimes very enthusiastically, about redesigning that system for this triple gain in terms of the benefit of greater efficiency, greater quality, and greater access. But they were educated under a different paradigm. In addition, yesterday's model of workforce needs may not address the complexity of healthcare reform or the current economic context, knowing that healthcare workforce issues are both a numbers as well as a distribution set of issues. So going back to it's the economy stupid, what I'm going to do is I'm going to present a couple of models that really have to do with, in this current economic context, as a Research One land-grant university under a state that's facing a tremendous amount of economic stressors, how do we do scenario planning, looking primarily at nursing workforce, but also I'll conclude by talking some about physician workforce. This is a paper that recently came out in the New England Journal. I think it was last week by Peter Bierhaus at Vanderbilt. He came out to Washington State University 2 years ago. He's the most prominent economist in the country really addressing nursing workforce. And in this paper, he proposes that the traditional models where we project how many students we educate and then what does that look like if you roll that forward in time, he's done something very interesting, and he's overlaid the recession on top of it. And so a couple of interesting things, something that you can't see, but I think everyone can understand a slope and a dot diagram, is that on the x-axis, he's put unemployment ranging from 3 to 10%. And then on the y-axis, he's really put the differential between projections and expectations in terms of nursing workforce. So if you translate this into what it looks like, if unemployment is very high, there is fewer nurses retire for one reason, because they can't. They cannot walk away. Oftentimes they're the only family member that has insurance, and so we see what Bierhaus refers to as the bubble, in terms of we're still educating, but people are not leaving. The converse, if you go into very, very low unemployment, people are more likely to leave the workforce, and we see a lot of variation. What does this mean? Oops, did I lose that slide? Just a second. I may have pulled out that slide, but that variation in the nursing workforce nationally can account for a variation in as many as 250,000 nurses nationwide out of a total workforce of about 2.9 million. So when we do kind of traditional, push the numbers forward, account for age, account for a number of people working full-time, part-time, and you roll that forward, and then you overlay the effect of unemployment on that, you've got essentially variation in here within 250,000 nurses. And it makes it very difficult to try and figure out how that critical access hospital in Colville or Davenport or someplace else is going to really have the type of workforce that they need in terms of nurses, nurse practitioners, and physicians. So just a couple of numbers. If we look at nursing education, about 2,500 candidates in Washington, public and private, took the exam for registered nurse. And so, and we use that as a proxy for new nurses. There's a little bit of wiggle room there if you don't pass the state board or you go someplace else, but that's the proxy that's used by the Center for Workforce Development, Rural Workforce Development, Sue Skillman's group at the University of Washington. So if we look at that, the recommendation about who has a baccalaureate degree, about 33% of those nurses total system-wide in terms of prevalence have a bachelor's degree. And then we look at the publics versus the privates. Washington State University graduates comprise about 31% of that group. Baccalaureate graduates from other Washington universities, of which there are 1 other public and 6 other privates, constitute the remaining 69%. If we look at graduates in public versus private institutions for registered nurses, about 54% are educated in private programs. So that would be Seattle U, PLU, SPU, Northwest. That's all I can think of right now. The publics would be University of Washington and ourselves. And then when you look at graduates among public universities for a bachelor's degree in nursing, currently, we educate 67% of the new nurses with bachelor's degrees. If we look at the impact of this in terms of just a family's ability that has a student that is interested in becoming a nurse or a nurse practitioner, physician's assistant, or pharmacist, this is the example of the tuition differential we see between the publics and the privates at this point, with the 2010 tuition at WSU being $8,600, 14% increase up to about $10,000, and anticipated additional 14 to 16% increase next year. We do compare that with what we see in terms of, and this is often offset with financial aid, but the privates in terms of tuition and fees in terms of $32,000 to $38,000 a year, which is something, a price point that a lot of families, and especially a lot of our first generation and minority students, really cannot afford. And when we're looking at distribution and having a workforce that meets the full range of the citizens, we think that that's important. So I'm going to show you quickly 3 diagrams in terms of 3 visions of the future. And I worked with Sue Skillman to develop these models, and that just shows what the assumptions are based on. How many nurses we have right now, what the percent of baccalaureate nurses, and the percent that stay in the state. So it's an interesting model. If you look at, so this goes forward, and I'm sorry you can't see because I've overlaid the footer on this kind of poorly, but if you go to 2031, which is farthest out this way, the dark blue is nurses growing up and living and working and moving out of the workforce. And then the lighter blue is new non-WSU BSN grads. The crimson is the new baccalaureate grads. The light is ADN to BSN because this is baccalaureate grads. So this is nurses that had a technical degree and they're getting a bachelor's degree. And then kind of the important point that I should probably figure out a way to highlight more is that this is us maintaining the supply as we see an erosion of state funding. At Washington State University, that net decrease in total university funding over the last 5 years is about 52% decrease in state funding over that period of time. But with that, we've been able to maintain enrollment. But even with that scenario, it would take an additional 1,000 nurses to maintain just the supply that we have. So that's slide number 1. If we decrease our one small place, and that's why I did this, our small place, if we decrease admissions 10% to our bachelor's program because of cuts or other types of things, then if we roll that forward in time, then our gap becomes 2,700 nurses if you roll that forward for about 20 years. And then if in terms of our base looks different, and we have to admit 20% fewer students, then if you roll that forward in time, all other factors staying constant, and so that's assuming constant across the system in terms of other schools, then the gap becomes about 4,500 registered nurses. So, it just gives you an idea in terms of the type of thing that we're trying to figure out in terms of, work with a very inspirational group of faculty and professors that take the mandate to educate nurses and nurse practitioners extremely seriously. And so this helps us try and think about in these difficult times, how do we try and address this societal need at a time that we have profound decrease in resources to us. So one other thing before I move into talking very briefly about physician workforce. I don't have any slides in here about nurse practitioners. At Washington State University, we make family nurse practitioners and psych nurse practitioners. This is really kind of the bread and butter of primary care. There's a paper that came out, I think it was about 6 months ago. Currently, primary care, about 18% of primary care visits in the United States are delivered by nurse practitioners. And I think for PAs, it might be about 8% or 9%, and then the remainder of primary care visits are delivered by physicians. So as we think about what that workforce of the future needs to look like in terms of getting this triple gain, I think everyone's looking at how do we align the need with the right provider at the right time for the right service with an eye on quality, recognizing how everyone works together to support excellence. So a couple of brief comments about, this is a really nice paper from academic medicine that essentially brings out the same point about the current primary care physician workforce, that most state programs have reached their approved capacity, and non-teaching hospitals are unlikely to be able to create new programs because the financial impact, just in terms of the lack of efficiency that you have when you're educating a lot of people in terms of doing that. And there are some assumptions that go with that as well. And then essentially this author notes that in terms of primary care physicians, we're seeing potentially another type of perfect storm here, the effects of the Affordable Care Act in terms of increasing the number of people that need care and have access to care, the obesity epidemic, rising chronic care, and the aging and continuing growth. And this is the complexity that we're really looking at in terms of addressing these needs. So I thought those were important points. Many of you know, and I'll steal Mary Selecky's thunder here. She's so brought the information in terms of the news release about the collaborative program with Washington State University and UW to really have a very novel step in terms of the WWAMI medical education program in terms of second year, and then really just an amazing conversation in this community about addressing the need for physician education in a very collaborative way, and it's been a pleasure to see that conversation. So more than quantity of providers, we also need providers that are embracing new realities in healthcare delivery and the delivery and transformation of services. And this has to do with delivering care in fundamentally different ways, addressing the piece of the pie that Mary talked about in terms of health disparities, recognizing that when we're talking about those who struggle most and oftentimes present in our emergency room with challenges with addiction or other types of things, needing novel approaches to really reach out and provide care. Healthcare, so in summary, healthcare reform will be designed by economists, as well it should be, because oftentimes providers are very poor at that. But in the end, it will be implemented by health providers and really embracing those cultural changes so that we're able to walk. We're asking our nurses, I spoke in Lynette Beer's class at 11:30 today, we're asking people to learn those technology aspects and how to be a good nurse or a good nurse practitioner or a good physician, and we're asking them to be the visionaries in the redesign of that system at the same time. That's the crisis, and that's the opportunity that we all face. So its success of healthcare reform will be predicated on strategies that reflect workforce realities, both in terms of numbers and distribution, support health science educational costs and the realities of those as we really continue to find efficiencies and embrace innovations in team care that you alluded to in terms of how do we deliver care in fundamentally different ways. And that's it, so thank you. It's my pleasure to listen to my capable, fun, and interesting co-panelists here. And so what I'm going to do is I'm going to ask people if they have comments or questions or commentary to please come forward to the microphone on my left so that, and I'd like them to indicate what panel member they'd like to respond to the question. Thank you.
My name is Dan Schaefer. I'm a retired physician with Group Health, and so I have a little bit of experience with the healthcare delivery system. And I'd like to ask a question based on some of my research on this topic, and I'll start with just a comment. There is always somebody who says, well, our healthcare dollars are because of our aging population. Well, in fact, Japan has the oldest population in the world. They exceed our life expectancy by 8 years, and they deliver health care for half of what we spend per patient per year. And if you look at all of the industrialized nations and how they provide health care, the two things that keep coming out that not only improve access, but also reduce cost that are not applicable to the U.S. are, number one, all basic health services in all of the industrial nations are provided on a nonprofit basis. You can buy for-profit insurance for additional things, but your basic health care needs are all taken care of by nonprofit insurance. The other thing is that they have universal rules and universal fee schedules and universal forms. Part of the reason our healthcare costs are so astronomical is the incredible complexity of our system. Every health insurance has a different fee schedule for every procedure. Every health insurance has different forms to fill out. The paperwork alone eats up 20 to 40% of the healthcare dollar in this country. And my question is and this really isn't addressed in the Affordable Health Care Act, but it's important to go forward with this. Is there any intention to at least make a universal fee schedules or universal forms so that everybody is dealing with the same information? And I probably will address this question both to Mr. Pierce and Dr. Schaaf, since they're involved with the systems. It's just a question. I think it's important that this be done in this country in order to make things work better, but I don't know whether that's a goal.
So I'm happy to start off on that. So, and we spent actually a fair amount of time looking at healthcare systems in other countries as well. And personally, my takeaway from those is that the one single example of a lot of those systems is that they do have price control. And I think that is something that in this society we're coming closer to. I think, for example, what's going on in Massachusetts right now, where you've probably all heard, in addition to Obamacare, you've heard of Romneycare. So that's a policy that was put in place in Massachusetts a few years ago. And so they're kind of a harbinger of, I think, of things that we might see. And so for a while, there's a lot of pressure on the insurance companies to reduce their rates. And more recently, it's been pressure on hospitals, physicians to look at lowering the cost of health care. So I think that's an important part of the conversation. What society needs to look at is what is driving those costs and where they derive from. And I think that there is going to be a fundamental shift within this country. Personally, I'm concerned about that kind of price control because I think that lends itself to a much different system than we have. And I'm not an apologist for the U.S. healthcare system. I think we have the very best healthcare in the world. And if I was going to be sick somewhere, I would just as soon be sick in Seattle or Spokane than in a foreign country. So I think we have a very good system. The cost of it is certainly broken and something that we need to focus on. In terms of the ease of administration, that's something that we, as a health plan, take very seriously. We have our own internal initiative to try and reduce our costs. Our margin, and frequently this surprises people, our margin over the last 10 years is roughly 1% to 2%. We take very little to do the administrative work that we do, but we're looking at focusing on reducing that even further. In terms of things that can be done across the system, whether it's forms, whether it's getting to electronic medical records, things that will improve the system and move healthcare into the 21st century, like banking and other things that have gotten more systematized, I think that's very important. As you know, there's a fair number of standard formats. I think we're going to go to more of those. And I think that is an important part of how we get to be more efficient and take out the redundancy in the system.
Yeah, I think I agree with you that one, taking the profit motive out is important. I mean, we still have to make a margin to have something to reinvest in the business and to implement new systems and the like. But the for-profit nature of much of medicine these days is problematic, contributes to the problem. I do think that simplification would be wonderful. When I was in private practice 20 years ago, I had, we had 4 physicians. I think we had 3 staff just did billing. It was crazy. We were, patients were giving us money, insurance companies were giving us money that we were then turning around and paying to people to just process the billing because it was 20 years ago, it was too complicated. In terms of price control, price control at some level assumes that we're going to continue to do fee-for-service medicine. And to the extent that we're doing too many procedures that don't bring any value to our patients, paying less for each procedure isn't going to get us less non-valuable stuff. It's not going to get us less complications. It's not going to get us a real change in the value of the healthcare delivered. So I think fundamentally changing the way that we pay physicians, other providers, healthcare systems is going to be critical to getting us to that triple aim of truly better care at a lower price, lower cost.
Just as a clarification, I didn't indicate price control. What I meant was that if you have a tonsillectomy, then Medicare pays the same fee as Blue Cross. I'm just talking about the same fee for the same procedure, not price control. You can control it, put it wherever you want, but everybody pays the same amount. That's what the other countries do.
But again, that's what I think of as price control. And if you have too many tonsillectomies being done, and you pay 20% less for them, if nothing else changes, there's a probability you're going to see 20% more tonsillectomies done. So you have to be a little careful about that. I think changing the equation of how we pay for health care is really the key.
And if I could, I would entirely support the notion of the federal government paying as much as the health plans pay for procedures. We have been very public about the notion that there is a massive cost shift from the feds and the states onto the private health plans, which is in turn borne by our members. And I think that's a real consideration to take into account as you think of more of a role of the government in that system. Again, at some point, it's the people in this room that pay for healthcare costs in this country, either through taxes or directly or some other fashion. And so we need to figure out the best way to do that.
Thank you.
Glenn Stream, I'm a practicing physician in Spokane, Washington. I aspire to the retired status that Dr. Schaefer enjoys. I appreciate the perspective of all the panelists. Each of you touches the healthcare system in a different way and has talked about the impact of healthcare reform. Within 3 months, the Supremes will determine whether the law goes forward or not. I'm curious for each of you what you see in your area that would go forward that was important, and perhaps what might not go forward if the law was struck down.
Mary, can we begin with you?
Well, if the whole law is struck down, then we are back to the whim of Congress funding public health through categorical grants dealing with body parts. And yet, here I am today imploring you on a very basic tenet of public health, which is stopping the spread of a communicable disease. In the economic state in Washington, your local and state governments continue to invest some, but not as much as we need in the very basics of public health. The fact that we have the focus in the Affordable Care Act on the whole system, state and local, including prevention, is really going to make a difference in the long run. Talking about the work I do with my colleagues, the amount of change that's happening at our Medicaid agency, which is at the Health Care Authority, is huge for them to be ready for 2014. We anticipate 450,000 Washingtonians will be eligible for more coverage. Now, a payment is a good thing, but if you don't have the providers, if you don't have the facilities ready, or you don't have the people knowing what they use that payment for, that's pretty tough. It took a long time as we covered children in this state 20 years ago, where we opened the doors and said all kids under 250% of poverty, we'll make sure that that payment source is there for you, because actually they're cheaper than any other population. And if we keep them healthy and well at that point, they have a healthier life. So it's going to take a whole culture shift with all of that. But I don't see, right now, parts of Congress are treating the Prevention and Wellness Fund as if it's their savings account and have dipped into it for the most recent tax breaks. So we lost $5 billion out of that fund already.
Other folks? Tom?
Well, for me on the delivery system side, much of what I'm working on right now has to continue because we have to decrease costs and we have to continue to work on quality and service. To the extent that group health is an interesting partnership between a delivery system and a financing organization, My health plan colleagues are going to be less free with funding my experiments on delivery system redesign if the ACA is undone, unless there is some clear follow-up that will be better. So, my work may get harder, but it won't change.
John?
Yeah, a couple thoughts. Actually, one thing that's very interesting to me is I understand the protocol of the Supreme Court is that they typically meet the same week of arguments and they make their decisions. So it could well be that they've already decided the fate of that law as we're all sitting here pondering what the outcome might be, although we won't learn about it until sometime in June. From our perspective, the most important thing is to make sure that if the individual mandate is struck down, that the aspects of the law, like guaranteed issue, also are looked at, because we think it's unworkable, as referring back to my earlier example, to have people have free access to the system only when they're sick and have it be sustainable. So we think that's a real significant issue. I also think that the issue of the funding that goes into the exchanges is going to be a significant issue. That is the kind of the economic driver of that piece of legislation, and depending on how active the court chooses to be with regard to reshaping the bill, it might affect that significantly. So that will be important, because it will dictate how many people go into the exchange and therefore how it affects the products that we offer. But just like Tom, whether or not that law existed, we would be doing a lot of the work that we're doing anyway, work that we started before the law was passed in terms of focusing on reforming the payment system, focusing on health and wellness of our members, and getting people engaged in the process.
I'll mirror a lot what Mary Selecky said. My background's in public health. I was saddened to see the alert come out about pertussis yesterday. We pushed that out to our faculty and our students. It's sad to see, I think what's summarized as a 57% increase in 1 year in terms of number of cases.
600%.
600%.
600%. From 84 cases during this first quarter last year to 640.
For a common vaccine preventable disease, this is a clear case where everyone can see that prevention pays. Surrounding people with a higher immunization rate means that transmission stops because it can't go from person to person, and it means that the cost of providing care for an acutely ill infant that may die is prevented completely. The second point really is the shift from hospitalizations more into the community where care can be delivered in a comprehensive way. There can be nurse-family partnership, the work of David Olds, the long-term impact of that type of care later on, even generations later, in terms of absentee rates in school, dropout rates, criminal behavior later on. There's some very, very common sense things that we know touch people in their homes in a way that make a very real impact in terms of the future capital of those children. Next question.
Trying to think of how to frame this question more in the healthcare reform, but this is primarily for Tom, but if John wants to comment on it as well. I'm Ann Montgomery. I teach at the Family Medicine Residency here in Spokane, and I'm also president-elect of the Washington Academy of Family Physicians. And in that venue, we get lots of data, and one of the things that came across our radar screen earlier, kind of late 2011, was when the insurance commissioner released the information about the increases in health insurance premiums in the state last year. And I thought it was absolutely remarkable that the group health HMO capitated population had a 0% rate increase where everybody else was in the double digits. My ex-husband has a group health individual policy, and his premium actually went down $4 a month in 2011. Is that because you guys are doing medical home, and in that population you've got a captive group that you can actually coordinate the care for? And if so, how are we going to get that into the other insurance products? We've had some medical home pilots in the state. Where are we going with that?
Well, I think our medical home project certainly contributed to that, because we showed that we could control costs while improving quality in that population using those techniques. I'm trying to think of the most polite term for how the steak of healthcare delivery gets turned into sausage of healthcare premiums, as it moves from what I do through the health plan process. But I believe that is certainly part of it. We were able to be pretty successful with medical home. How that's going to translate into other payers, frankly, in the near future, I'm hoping that my delivery system can be a delivery system for John and his colleagues, as well as other insurance companies in the state. My goal around Medical Home 2.0 is that this is something that will serve the people of this community more globally than just the small population of group health members that we have now. So to the extent that I can accomplish that with my group and the work we're doing, and that we can teach other groups around the area and around the state about how to do this, I'm excited about that.
I guess the way I can hook it on to health reform is we're going to have to make the exchanges cost effective, and so
Yeah.
models to do that.
Yeah, absolutely.
Bob?
Thank you. I'm Bob Pringle, and I work here on campus, but my question has to do more with the payment methodology. And I just wonder, since all of you are highly involved or affected by the current payment method, fee-for-service, Medicaid, Medicare, et cetera, with the federal government being the big driver in that arena, what have you done? What do you think you might be able to do on a state level with the Medicare, Medicaid payments that the state is involved with, and your agencies in convincing the federal government or whoever else is involved with those payments that the fee-for-service needs to change? In other words, the education up, or if you will, the lobbying. Are you involved in that at all, or what? Thank you.
I'll take a stab at it from the state government end. Until Medicare opens, I mean, the big kahuna is Medicare, and Medicaid will follow. It doesn't happen the other way around. The populations may be different, but indeed that's kind of how that would happen. We, Washington State, have made several proposals to the Center for Medicaid and Medicare Innovation about doing things differently, and unfortunately, some of the mindset is still trapped in the fee-for-service, but we keep trying. The governor visits with the Secretary of Health and Human Services. They have a great conversation. She was the insurance commissioner in Kansas, but you get down into the system and it gets harder to change. Our ideas around the table at the health cabinet really are much more about the managed care. And there are some federal laws that don't have certain populations in that kind of care, but it would make more sense. So I think it's going to be that payment reform that's going to have to happen on a global basis, not excluding anybody, insurance companies, et cetera, but making it possible for them to design products in the same kind of way that pay off in terms of a healthier outcome, let alone spending less money.
And I just offer two things. One is I think, and back to an earlier question, the work of the ACA put in place what's called accountable care organizations, or ACOs, which are, I think, closely aligned with the notion of a medical home, the notion that you're going to bring people together in providing more comprehensive care that's in a different model than it's been in the past, and be more effective and therefore more cost effective. I think that is a very good part of the bill. It remains to be seen how that will take on. Medicare, I think, has been working hard on figuring out how that reimbursement mechanism will work and getting providers to come to it. So I think that could be a real positive outcome. And I think we just need to continue to focus on how we address those costs holistically.
Yeah, the ACO part of the legislation is problematic in terms of actually following that part of the legislation. When it first came out, we were pretty excited about developing an ACO per se, and I would say in spirit, that's really what we are trying to build, to where we can take on a population, get paid up front, and then use that money to manage the care and to manage the delivery system in a way that makes sense for everybody. To the extent that group health has been successful, and that other organizations like Mayo Clinic, their docs are on a salary, that we can show that approach to care to paying physicians and other providers makes sense and gives very high quality care at a reasonable price, I think that the federal government will catch on, that other payers will catch on, but can only hope.
We have time for one more brief question and one brief response, if there are any.
Hello, my name is Becky Kerfman. I'm a nutrition and exercise physiology student here at Washington State University. And I suppose since we're trying to make it brief, I'll direct this to Secretary Selecky. But really, you all mentioned it in your talks, and regardless of whether or not the law passes, about the importance of the shift to preventative care. And the preventative health care that was addressed today was with regards to vaccinations and preventing diseases that way. But you all mentioned the great problem that's caused by unhealthy lifestyles, smoking, and many factors that are going to contribute to this incredible increase in healthcare costs, particularly if the law passes with all these new people who will be covered under it. And I'd just like you to elaborate a little bit on what you foresee of the preventative healthcare to address those unhealthy lifestyles that's going to come through just in the future of our healthcare situation.
Thank you for that question. I appreciate it. One of the things we do is have to count on multiple prongs. One is clearly the intervention that a healthcare provider has with a patient, a client, is one of the most important. We've learned that through tobacco use. That's the only way we really get pregnant moms to quit, is when their docs really talk to them. But they've got to go into a supportive community. Around them, there's going to be smoke-free atmospheres. Same thing with eating. You go to places, and if you don't have healthy choices to make, doesn't mean you have to give up the maple bars, but at least give a choice so you can pick something else now and then. Or restaurants that are serving, moon-size kinds of portions instead of smaller plates. You usually end up spending more money on less food when you go to some restaurants, but places where traditionally everybody else eats, you're getting huge amounts. How do we make those changes? Yesterday afternoon, I spent an hour with one of the leading professionals at the Restaurant Association, talking about how we could make a partnership and perhaps deal with the sodium issue. And what would it take to do that? And the culture change the population would have to go through, because think about when you've stopped sprinkling salt, if you have, and if not, try it. Chicken soup has a whole different flavor without salt, but you get used to it after a while. It will take all of that. It's got to be a comprehensive, supportive kind of atmosphere, not just a one shot. The only way that we really pay attention to this is when it hits us and our health or in our family. When you look at the determinants of health, 96% of the money is spent on the illness care system and 5 to 6% on prevention. Yet more than 50% of how healthy we are is determined by our behaviors. So guess who's in control? You are.
Let me thank our audience for coming out today and also for their terrific questions. Join me now in thanking our excellent panel for a really interesting discussion.